Hi guys, welcome to this recall of Obstetrics and Gyne question of today's exam, MCI July 26th. And I'm so excited. I'm so relieved that all what we had stressed upon in the classes has come in the exams. I told you, बोला था तुम्हें कि Bishop's Code पढ़ के जाना, उसे रट के जाना. Then I told you about the alternative names of common things like dermoid tumors and mature teratoma came in the exam. And then we had something about fetal surveillance. NST came and CDG also came. So yes, please always remember the things we impress upon and they are likely to come in the exam. Quickly, let's see the answers. I know you have so many places to go because you have to see all the other 18 subjects also. So let's move on and see the answers. Fatafat, the way they have been recalled to me, that's just the way I'm just recalling the questions just in that manner. Right, guys? So the first question coming up, picture of an ovarian tumor with hair and teeth. Yes, guys, what do you want to call it? You want to call it the dermoid tumor or the mature teratoma. It is also called the benign cystic teratoma. All right, the same thing. So benign cystic teratoma or the mature teratoma or the dermoid means all the same. All right, guys. So hair with teeth, dermoid tumor. Then what is the sign of early pregnancy where you put one hand on the abdomen, one hand in the vagina and try to go through the isthmus of the cervix and it is so soft that you can touch your fingers through the isthmus. I have also told you that be careful of this sign that if you are a little careless, you may go a little up and squeeze a gestation sac and cause an abortion. I told you not to do this sign. And actually, we had a lot of fun at the cost of this sign, but this is not the place to discuss about that. Yes, this is the Hagar's sign, guys, and I'm sure around 6 weeks it is seen, and all of you got that correct. What is the next question? Which of the following is not a contraindication to COCP use? So very important to understand that uncontrolled diabetes, uncontrolled lipids, uncontrolled hypertension, these are all the conditions where we are not going to use COCPs. But yes, right in the chapter of COCPs in our workbook, everywhere we've told you that HIV and STD is not a contraindication to COCPs. I'm sure you got that right. Okay, Shelley. Remember, I told you in the revision class which I took on YouTube around a few days back, MEC 1 and MEC 2, MEC 3, MEC 4, the medical eligibility criteria. In the medical eligibility criteria, MEC 1 and MEC 2 are generally the criteria where if you say that OCPs in a patient with HIV, what is it? Okay, it is MEC 1 that you can give HIV patients COCPs as a contraception without any problems. So that is MEC 1. And MEC 4 means that, okay, if a patient is having vaginal bleeding, can you give an IUCD? No, you cannot give because undiagnosed vaginal bleeding, you cannot give IUCDs. That is MEC 4. All right. So yes, for a quick recall, I've given you what is MEC 1, MEC 2, MEC 3, and MEC 4. And I was just hoping that one of these exams, this will come, and it has come right in the exam within a week of our discussion. So please, whenever you're reading any contraceptive method, read about the MEC 1, 2, 3, and 4 also. Right, guys, let's move on. What is an absolute contraindication for IUCD use? I think the choice came, which all of you answered, undiagnosed vaginal bleeding. And remember, I told you last week itself that ectopic pregnancy in a previous pregnancy is not a contraindication for using IUCD. All right, because IUCDs do not increase ectopics, they reduce pregnancies and they also reduce ectopic pregnancies. All right, so that is also MEC 1 IUCDs with the previous ectopic is MEC 1. I showed you the chart also. Okay, guys, what is co-test of HPV? Yes, when you're doing a pap smear, along with the pap smear, you do the HPV DNA assessment. That is a co-test. You know this one, I'm very sure. Then, where do you see variable deceleration? Now, variable deceleration is that hotshot topic. I told you that fetal surveillance, don't leave your homes without reading fetal surveillance. And I'm so proud of the fact that I impressed upon this wherever we met. And I'm sure you wrote that variable deceleration is seen in umbilical cord compression. And remember, early deceleration is seen in head compression, and late deceleration is seen in placental insufficiency. Groove on the abdomen is felt or seen. I don't know what was the MCQ. Groove on the abdomen is felt when a patient is in labor. I think they would have written obstructed labor. But when this groove is felt, that means the uterus is under a very strong spasm. The upper segment has contracted so much, and the head is not going through the pelvis because the pelvis is narrow. It's a cephalopelvic disproportion. So you feel a ring in the uterus at the junction of the spastic upper segment and the relaxed lower segment, and that is known as the constriction ring, retraction ring, or the pathological constriction ring. So remember, constriction ring and retraction ring means the same. Constriction ring or the physiological retraction ring means the same. So I'm just writing as the choices came. But what we have seen in this question, groove on the abdomen is a pathological retraction ring of Bandel. All right, it is higher in the abdomen versus the physiological constriction ring, and it is palpable per abdomen. Remember this picture which I showed you, we discussed in great length in the introduction of our class. Within the first, I correlate the normal anatomy and the isthmus along with this intricate diagram of labor, and we all understood it within first 2 hours of our classes wherever we've met. So I hope all of you will go back and see your notes very proudly and remember that it came in your exam. All right, guys, let's move on. Blue cervix in pregnancy. Yes, blue cervix or blue vagina. I told you last week itself, it is Chadwick sign. So don't think it is only in the vagina. It is actually classically mentioned for the cervix. It can also, obviously, the cervix is blue, the vagina also surrounding it will be bluish tint, isn't it? So it is for the cervix and also for the vagina. Now, this is the slide which I wanted to show you. This that slide of the fetal surveillance test, and that is the intrapartum fetal surveillance, and that is cardiotopography. And variable deceleration is the one on the top. You can see here, variable deceleration is the most common deceleration, and it is seen in umbilical cord compression. All right, guys, I'm sure you knew this, and let's move on. We already discussed this part. Okay, placenta on an ultrasound shows to be going through the uterine muscle and invading into the uterine bladder. And what was the information given along with this? That it is associated with low-lying placenta. Guys, I've been screaming hordes telling you that placenta, yes, you know the answer, it is placenta accreta, increta, or percreta, one of these. So this placenta accreta syndrome is most commonly associated with what? With placenta previa and with previous LACS. Remember, placenta previa is more common, and that's what has come in your exam. Now, remember for the rest of your lives what I told you, and it has come exactly like that. So, placenta previa is the more common association with placenta accreta syndrome rather than previous LSAs. Yes, previous LSAs, the volume is too much because so many people are having cesarean section. So, it is not a, it is just that the sheer number of LSCS makes you think that there is more association with that. The association is classically more with placenta previa, and that is what is given in your Williams also. So yes, what is the answer to this? Where the plasma is invading through the uterine muscle into the bladder mucosa. So that is what is placenta percreta. Within the uterine muscle, it is placenta increta, and just touching the uterine muscle and not going inside is placenta accreta. All right, so answer is placenta percreta. OCPs do not reduce which cancer? Colorectal cancer is reduced. Endometrial cancer is reduced. Breast cancer, there is no effect on the incidence of breast cancer. It does not reduce, it does not increase. Ovarian cancer is reduced. Was C cervix also a choice? If C cervix was a choice, then that is also an answer. So I've given you two answers here. One is that C cervix is not reduced, and the other one, endometrial breast cancer is not reduced. All right. So please remember, CA cervix can rarely happen with COCPs, but that's not the CA cervix which we generally see in our OPDs. The most common cervical cancer which we see in our country is the squamous cell carcinoma. Rarely, because of COCPs, there can be a cancer of the cervix, and that is the adenocarcinoma. Very rarely. All right, I've yet to see it in my life as a gynecologist of 29, 30 odd years. I have yet to see a CS service coming because of COCP's usage. It classically is seen in a country because of the HPV virus association. All right. Now, this is a very favorite question for MCI. Remember, I keep telling you there are some domain questions, sealed questions for MCI, and that one has come. What is the cause of amenorrhea after DNC done for a woman who wants an MTP at 29 years of age? So, yes, this is a DNC can cause endometrial injury and cause Escherman syndrome. All of you got it correct, and I'm sure that you remember I told you that 180 questions are the ones which are going to be just the simplest of answers, and I'm so proud that out of those 180 questions, majority came in gynecology. So I'm very happy for that, and I'm sure all of you got this correct. Let's move it. Pap smear. What is the best method to do? Now, I'm not very sure what question was asked. A lot of you said they asked what is the best method which correlates with sensitivity. So we always say cost effective is VIA, but the best method of screening is Pap smear. pap smear sensitivity is not very great. It is 48% to 62%. So as a method of screening, which is the best method of screening of CA cervix, what is the method which has reduced CA cervix incidence by 70%? All these answers are pap smear. Now, which is the cost effective method of doing assessment of CA cervix? That is VIA. All right. So I am not sure what question came. So let's move on. And face presentation, what is the diameter of engagement? Remember, always in labor class, I've shown you on the dummy, then I've shown you on the book, and sometimes I've shown you on my own face. And you remember I told you that when the head is extended, then it is going to be a face presenting part, and the diameter is submentopragmatic, isn't it? And the denominator is the chin, the mentum. All right. Now, this question slightly tricky because a lot of you sent me this picture and they were told that is the answer McDonald's cerclage or a Shirodka cerclage. So I'm just telling you this picture. They are showing you that there's an incision made on the top of the cervix, and we are actually pushing the bladder up, and then we are trying to go through the this incision onto the cervix and making a stitch. So when you make an incision on the cervix, and we are trying to push the bladder a little up and then place a stitch, then that is classically Shirodkar's stitch. Okay, so if this was the picture, I'll answer Shirodkar's. Otherwise, McDonald's cerclage is a very simple cerclage. This is the uterus and this is the cervix. So we just take bites. We just take bites of needles through the cervical tissue and just place a stitch. So one of the easiest cerclages is the McDonald's cerclage. We don't make an incision like this. So if there was an incision made like this, mark Shirodkar's, because Shirodkar is done for failure of previous cerclages or a very short cervix. Incidentally, today morning, one of my patients of Shirodkar came back for a follow up. We had done a Shirodkar for her around 5 years back. When you do a Shirodkar, we have made incisions like this. So you cannot remove this Shirodkar because the stitches are hidden under the vaginal mucosa. So she has to have a cesarean for a delivery. Now she's come back and asked me, sir, now my baby is around 4.5, 5 years, and I want to have another child. So will you put another stitch? I said, you already have a stitch in place because Shirodkar will stay even after the cesarean delivery of the last time. Now she can get pregnant again. Throughout this pregnancy, the Shirodkar will be there. And after this delivery, if she doesn't want to have a child, then we remove a Shirodkar. All right. Because there is a modified Shirodkar where we keep the stitch in the lower part of the stitch in the vagina so that we can remove it if we want. Otherwise, the way it is shown here, if it is anteriorly and the posteriorly, if the stitch is hidden into the cervix anteriorly and posteriorly, then you cannot remove it lifelong. All right. So Shirodkar is unlikely the question which came to you. I'm very sure McDonald's came to you. Neat guys, if you're seeing this, remember Shirodkar can come in your exams. Okay, guys. Let's move. And guys, another MCI domain question. What is the management of shoulder dystocia and what is the first step? So yes, remember any woman delivering, she's always holding her legs and flexing the hip joint. We always encourage that because we tell them hold your thighs, pull them towards yourself, raise your head, look at your umbilicus and push, isn't it? I remember doing that in Tamil when I was doing my MBBS and MD in Jipma. So yes, when you're doing this, and there's a shoulder dystocia. When you're doing a delivery and a woman has shoulder dystocia, we just push the knees onto the mother's abdomen. We hyperflex the hip joint more than 90 degrees. That's naturally the first step of management of shoulder dystocia, the flexion of the hip joint more than 90 degrees. And next step, if it doesn't work, then we put a suprapubic pressure. If it doesn't work, then we do the Woods corkscrew. If that doesn't work, we try to push the head back into the vagina and do a cesarean. Javanese restitution, easier said than done, associated with almost 70% mortality of the baby, but at least we can save 30% if Javanese, it has gone to the limit of doing the Javanese restitution. All right, but remember the first step is flexion of the hip joint, Mac Roberts maneuver. Okay, and another domain question for MCI students, inversion picture was given. I'm not sure whether I can use the picture which you guys sent. So inversion of the uterus is classically associated with delivery done by untrained people. Now did they mention an intern has done the delivery? I mean, I'm seriously upset. I'm going to write a note to NB that this is not the way to make questions. Please, inversion has happened many times with senior people like postgraduates, senior residents, and even consultants have done inversions. So always, there was this question in 2022, and within 3 years, I've been telling that they wrote intern in 2022 MCQ for MCI. Again, they've written interns. it's a little derogatory. So if they write untrained people next time, I'll be happier. So yes, untrained people, plasma attached at the fundus and a multiparous woman. These are the kind of conditions where inversions are common. It is associated with a lot of bleeding, and hemorrhagic shock is the most common cause of death in a patient with inversion. All right. And to reposit the uterus, first you must relax it with terbutaline, push the uterus back inside with your fist, and then contract it with oxytocin. We discussed this just around a week back on a YouTube record. Now, there was another question about perineal tear. Perineal tear, which is involving less than 50% of the external anal sphincter. What is that type of perineal tear? So remember, we discussed in our workbook, and I gave you this picture where we have discussed type 1 tear is involving the vaginal mucosa, type 2 is mucosa plus the muscle, and type 3 is involving the anus. Now, anal sphincter tear, if it is less than 50% of the external anal sphincter, it is type 3A. That's what has come in this MCQ. I hope the choices were given like that, type 3A or type 3B or type 3C, like that. So type 3A is less than 50% of the external anal sphincter, type 3B is more than 50% of the external anal sphincter, and type 3C is the internal anal sphincter tear. Of course, if the rectum is involved in the perineal tear, it is type 4 tear. And type 3 and type 4 both are known as complete perineal tears. So I'm sure you got that correct. Then a woman is at 33 weeks and 4 days pregnancy with preterm labor. What is to give for the lung maturity? You have to give steroids, and dexamethasone and betamethasone are just equally good. They are both equally good, just as good. And that's why we say that we must remember the dose of dexamethasone always. This time, I don't know whether they asked you about the dose or not. Okay, so 6 milligram 12 hourly 4 doses of dexamethasone, or 12 milligram 24 hourly 2 doses of betamethasone. Right. Irregular vaginal bleeding. What is the best method to do a biopsy? So remember, I have told you this many times. If a woman has irregular vaginal bleeding, examine her first and then assess the endometrium. If there is no vulval, vaginal, or cervical lesion, assess the endometrium in the OPD itself, people biopsy. Or take her to the OT, you can do a DNC. Better than people biopsy, but not the best, because the best is hysteroscopic biopsy. So, answer is hysteroscopic biopsy. I'm sure you got that correct. Partogram, there was a question. A lot of you have not been able to give me the exact wordings. I hope they asked you about the WHO partogram, which we're using in the labor rooms. Whether the 2021 the labor care guide WHO partogram came, please write me in the comments below. But whatever partogram came, most of you said it's the one which I showed you in the classes. And patient in labor with cervix not dilating beyond 3 centimeters, even with 40 international units of oxytocin, I think it must be the concentrated, oxytocin drip, because we never give 40 units for labor. So it must be the syringe pump, which, it's generally 2, 4, 6, 8, like that we give oxytocin, and not 40. So if it is 40, it has to be a syringe pump in which we are giving the oxytocin. Anyway, so whatever oxytocin drip rate and all, you've not told me, whatever oxytocin was given, they were good contractions and the membranes are intact, but the cervix is not dilating beyond 3 centimeters. So what is the next step to do? It's always an obstetrician's, first instinct. If the cervix is not dilating, we go ahead and rupture the bag of membranes, because that releases prostaglandins, and prostaglandins induces or even augments labor. So here we want to augment it. We have given oxytocin, we also do artificial rupture of membranes. That's the best thing here. Oxytocin is the hormone for milk production or milk letdown. Last week we've discussed on YouTube, it is the hormone for milk letdown. Production is prolactin. Okay. Breast and pubic hair are developed. What is the next step in the? I'm sure the question is about female's puberty and what is the series of events. So first is breast, next is pubic hair, next is height, and the last is the periods. So when a patient has uh, breast and pubic hair, the next step is growth in the height. And once the girl gets a periods, the height growth stops. All right. That's why precocious puberty is not so good. Once a girl gets period, let's say at 7 years, her height growth will stop. That's why precocious puberty is not good. Please understand, and then you'll remember for life. Now, just before I was recording this video, some students send me these MCQs, some good recalls after some patchy recall of most of the questions. I got some good recalls, and thanks, Dr. Merrill. Okay, so 45-year-old woman from an affluent background described as a workaholic, presents with complaints of irregular heavy menstrual bleeding. for the past few months. She mentions that her mother had similar menstrual problems around the same age. What is the most likely cause of a condition? No, it's not endometrial cancer, because endometrial cancer will give you a much, you know, definitive history of diabetes mellitus, hypertension, obesity, like that. So that's not there. It is most likely anovulatory bleeding, because around 40 to 43 to or 50 years of age, most women will have anovulatory cycles. And I've been hammering this detail. I've caught some of you guys, and I've shook you up to tell you ovulatory cycles are regular, anovulatory cycles are irregular, ovulatory are painful, anovulatory are painless. Remember all that? So yes, it is just that information which has been asked here, the introductory classes which you have. And it can be hypothyroidism, but they are suggesting hypothyroidism can present with the similar complaints, correct, but more information should have been given. And it is completely normal to have such. Yes, this is also completely normal, but not menorrhagia. Irregular cycles is okay, but not menorrhagia. So it is DUB because of anovulation, the best answer to this. Now, interesting question. Despite the presence of microorganisms in the lower genital tract, ascending infection to the upper genital tract are relatively uncommon. What is the primary reason for this natural protection? Some students send me this question in a different way, saying that the vagina is anatomically very close to the anus. Why don't women have too much of vaginitis because of the fecal infection? So, answer to both these scenarios is the same. Vagina has acidic pH, which is because the estrogens and the lactobacillus. This gives natural immunity in the vagina. Lactobacillus will use the glycogen for its nutrition and break down the glycogen to monosaccharides, in the process releasing, yes, lactic acid and H2O2, and that's what gives natural protection. So I think the best answer here is acidic pH of vagina, which inhibits microbial growth. The microbiome of the vagina is like that. The lactobacillus is the friendly vaginal bacteria, which is going to help prevent the infections. Right? I'm sure you got that correct. Hot flush in menopause, what is the preferred choice of treatment? Remember, I've been telling you and hammering this detail that please, drug of choice for osteoporosis in menopause is estrogens, and after 60 years it is bisphosphonates. Now they've again asked you a question related, that they're asking you hot flushes treatment, what is the preferred drug? Obviously it is estrogens, because estrogens will reduce the hot flushes, very the best treatment of hot flushes. Along with that, they will also take care of the bones. Okay, so the answer is estrogens. Please say progesterones can help in hot flashes, but not as much. Estrogens is the drug of choice, and raloxifene cannot be given, because raloxine's own side effect is hot flashes. Right. Which is the surgical procedure to be done if all medical management fails to control postpartum hemorrhage? So I don't know what was the exact history, but here you should remember that after the drug of choice is oxytocin, and then we can try methyl ergometrin, even carbetocin, misoprostol, which is PGE1, but the go-to drug is always carboprost. Now, till carboprost has been used and it is not stopping the bleeding, so now we have to get to surgical management. One of them, the first one to do is the tamponade, the balloon tamponade by Bakri's balloon. If that doesn't work, we can, make an incision on the abdomen, deliver the uterus outside, and put a B-Lynch hemostatic suture. And if that doesn't work, you can go for uterine artery ligation, internal iliac artery ligation, and even if that doesn't work, we do a hysterectomy. So that's the chain of events. I don't know how this question was asked, but I'm sure you would have got it correct. Okay, guys. Right. Rigid maneuver, what is the purpose of it? So rigid maneuver, you know that you put your hand through the perineum of the lady who is delivering and put your hand towards the fetal chin, pull it forward, so it promotes deflection and then extension of the fetal head, and that will help in faster delivery of the baby also. But in addition to that, it is going to prevent the perineal injuries, because it's a controlled deflection and extension of the head that prevents perineal injuries. All right. So that's the purpose of the rigid maneuver. We discussed that in the classes. A woman presents with 7 weeks of amenorrhea, a transvaginal ultrasound is performed. Which of the following findings confirms an early pregnancy loss? Classical radiology question. I'm sure your radiology teachers are going to give you a better answer, but this one I also know. So please, we do these ultrasounds regularly as obstetricians also. So whenever the crown rump length is 7 millimeters and more, and you don't see the cardiac action of the fetus, then we say that the baby is not going to be a viable baby. Now, There is another criteria, that is if the gestational sac is more than 25 millimeters big and you cannot see a cardiac activity, then or fetal node or a cardiac activity, then we say that is also a non-viable pregnancy. All right. So the answer to this question is B or 2, what is given here. CRL greater than 7 millimeters with no cardiac activity. A fetus is delivered via vacuum assisted vaginal delivery. Where should the vacuum cup be ideally placed? So, this question came last year in NEET, and I was telling you that it's not that NEET questions won't come for you. And exactly that's what has happened. The same question has been repeated, and the vacuum cup has to be put on the head near the posterior frontal. So, generally, what we do, we put it just below the posterior frontal. So, the choice has been recalled just like that, 3 centimeters anterior to the posterior frontal. All right, so that's the answer. And yeah, let's move on. Now, this is the favorite tease to all my live student classes, that please mug up the bishop score. Every time you see the bishop score chart, you keep coming and asking me, sir, ये एग्जाम में आएगा, ये याद करना है, आ गया, देखो आ गया है. Please, 3 out of 5 exams in a year, this question is coming on Bishop score. Please mug it up properly, and you must discuss with your friends. Give examples and discuss with your friends, because it is tough to remember. Once you get into your system, you'll be able to answer. But fortunately, they asked you a very simple question this time. Which of the following is a unfavorable Bishop score? So 4 and less score is unfavorable. 9 and more is favorable Bishop score. So there's only one value here, 5, 3, 7, and 8. So 3 is a unfavorable Bishop score, and 9 and more is favorable. All right. So there are these 5 parameters. I'm sure you know this chart well by now. And if you don't know about time, especially all you need PG students, please mug it up. And those who are seeing this before the Jan 26 exam, please mug it up properly. So, all right, these were the questions given to me. I checked a lot of groups, but I'm sure there were a few more. In fact, somebody said there were 40 odd questions. So, if those questions come to your mind, you can always keep typing them in the chat below, and I'll keep answering them. Especially if you're seeing this before the Jan 26 exam or some other later exam, even for the NEET PG coming up. So, this is an ongoing process, and we'll keep engaging you for all the best answers. So, all the best, guys. Keep reading very hard.